Hey everyone! Today we're jumping right into the endocrine system. You know, that whole network of glands that's supposed to keep our bodies running in perfect rhythm. But what happens when that rhythm gets thrown off? We're going to look at that delicate balance, focusing on the thyroid, parathyroid, and adrenal glands, and see what happens when things go into overdrive or just grind to a halt. So here's our game plan. We'll kick things off with the thyroid and its two extremes, then dive into some pretty serious life-threatening emergencies. After that, we'll talk about the parathyroid, calcium's keeper, and then the adrenal glands. And we'll wrap it all up with a question for you to chew on. Let's get into it. All right, first up, the thyroid gland. I want you to think of it like the engine of your body. It really sets the pace for your entire metabolism. And what we're going to do here is look at the two big scenarios. What happens when that engine is running way too fast? That's hyperthyroidism. And what happens when it completely stalls out, which we call hypothyroidism. So what's actually doing the work here? Well, it's this little butterfly-shaped gland right in your neck. It pumps out two really important hormones, T3 and T4. These guys travel all over your body, basically telling every single cell how much energy it should be using. It's so fundamental, right? It affects everything from your heart rate to how you burn calories. And this slide just lays out the two extremes perfectly. With hyperthyroidism, that engine is overheating. Your metabolism is floored. You see weight loss even though you're eating more, a racing heart, and you feel hot all the time. On the flip side, hypothyroidism is that engine stalling out. Everything slows to a crawl. You get weight gain, you're tired, your heart rate is slow, and you're always cold. They're literally polar opposites, which makes perfect sense when you think about it. So why does the engine stall? Well, the number one cause is Hashimoto's, which is an autoimmune disease where your body just attacks its own thyroid. But look at that second point. This is so important. A major cause of an underactive thyroid is the treatment for an overactive one, things like radioactive iodine or surgery. So you can fix one problem and, in the process, create its exact opposite. That's a huge takeaway. So, how do we manage these conditions? Well, it's a really clear, systematic approach. It all starts with looking at symptoms and getting a good patient history. Then you move on to lab tests for TSH, T3, and T4 to see what's really going on. Once the diagnosis is confirmed, you pick the right treatment, and the last two steps are absolutely critical. You start the therapy, and then you monitor to make sure you get that patient back into a balanced state, what we call euthyroid. Okay, now we're going to pivot to the most severe, absolutely life-threatening forms of these imbalances. We're talking about thyroid storm, which comes from extreme hyperthyroidism, and myxedema coma from extreme hypothyroidism. And these aren't just worse symptoms, you guys. These are full-blown medical emergencies that need immediate and very different types of intervention. During a thyroid storm, the body is just burning itself up. The goals are simple: get that temperature down, get that heart rate down, and prevent a total cardiovascular collapse. We're using cooling blankets, giving IV fluids with dextrose because the body has burned through all its energy stores. And here's a massive safety alert. You have to avoid salicylates, like aspirin. Why? Because aspirin actually kicks thyroid hormone off its binding proteins, which makes more of it active and just throws gasoline on the fire. Now, the game plan for my myxedema coma is totally different. Here, the body is shutting down. The goal is just to support vital functions while you gently, carefully get things back in balance. Notice we use passive rewarming, just blankets, not active heating pads. If you warm them up too fast, you can cause their blood pressure to plummet and put a huge strain on the heart. It's a slow, careful dance of support and correction. And when surgery is the answer, what happens after is so important. This alert right here points to one of the most critical post-op checks for thyroidectomy: listening to the patient's voice. Any change, like hoarseness or any trouble speaking, is a huge red flag. It could mean there's swelling or even nerve damage right near the airway. It's a simple thing to check, but it can absolutely save a life. All right, let's switch gears and talk about these tiny little glands with a massive job, the parathyroids. They are the body's absolute master regulators of calcium, and when they're not working right, you see the effects everywhere. So how does this all work? Well, the parathyroid glands release something called parathyroid hormone, or PTH, and PTH basically has a three-point plan. It tells your bones to release calcium, it tells your kidneys to hang on to more calcium, and it tells your intestines to absorb more calcium from your food. It's this coordinated effort that keeps your blood calcium in a super tight, healthy range. And when that balance is gone, the symptoms are all about calcium. Too much PTH means high calcium or hypercalcemia.
There's a classic saying for this one: stones, bones, groans, and psychiatric overtones. It's memorable because it's true. Now, on the other side, too little PTH means low calcium or hypocalcemia. This makes the nerves and muscles super excitable, leading to cramps, tingling, and even tetany, which is this state of involuntary muscle spasms. And this is a really cool way to see that neuromuscular excitability in action. This is Chavostic sign. A clinician can just tap on the facial nerve, and if the facial muscles twitch like you see here, that's a positive sign. It's a clear signal that calcium levels are low and that the patient is at risk for tetany. All right, our final stop on this tour is the adrenal glands, the little glands that sit right on top of your kidneys. We're going to focus on the adrenal cortex. That's the outer part, which makes these essential steroid hormones that help us deal with stress and regulate our metabolism. And you guessed it, we're back to a tale of two extremes. Cushing syndrome is all about adrenal access. You've got high blood sugar, weight gain right around the middle, high blood pressure. In total contrast, Addison disease is adrenal deficiency. So now you have low blood sugar, weight loss, low blood pressure, and this really distinct bronzing of the skin. Now, the most severe form of this is an Addisonian crisis, and this is an absolute medical emergency. We're talking about a state of profound shock because the body has no adrenal hormones left. And one of the most critical things to know here is that it can be triggered when someone who's been on long-term steroids suddenly stops taking them. This is why patient education about never, ever stopping steroids abruptly is so important. Managing this crisis is all about speed. The main goals are to fight that circulatory shock and get the blood flowing again. You do this by pushing IV fluids and, this is the key, replacing that missing steroid with IV hydrocortisone. Putting the patient's legs up also helps get blood back to the heart. You really can't waste a second. Now, we've mostly focused on the adrenal cortex, the outer part. But the inner part, the medulla, can have its own major problem, and it's called a pheochromocytoma. This is a tumor that just dumps massive amounts of adrenaline and noradrenaline into the system, causing these episodes of incredibly severe, potentially fatal high blood pressure. So we have walked through this really delicate endocrine balance and seen the pretty dramatic results when it all goes wrong. We've covered how clinicians have to manage these disorders, especially when they become these life or death crises. And that brings us to our final thought. We've spent a lot of time talking about reacting to these big crises: thyroid storm, myxedema coma, Addisonian crisis. But these are the endpoints, right? They're what happens when things have already gone very wrong. So the real challenge is this: how can we, as healthcare professionals, get better at using patient education to stop these things from ever happening? How do we empower people to manage their own health so they never reach that crisis point? That's something really worth thinking about. Thanks so much for joining me today.